Hello, today we're going to be in Module 6 and we're going to be talking about a couple more topics from Chapter 2. This will be the last of Chapter 2, so if you haven't read that yet, please do so. But today we're going to be talking about attributable risk and diagnostic testing. First, let's talk about attributable risk. We've talked about this a little bit when we talked about risk difference, but we're going to take that a little bit further today. So attributable risk allows for researchers to estimate how much burden a particular disease gives or supplies to a population. This is really only relevant when a risk factor is modifiable or changeable. So if it can't be changed, then there's really no reason to estimate how much burden it provides. But for instance, if, say, a government wants to spend money to try to reduce the risk of disease, well, are they going to spend money trying to reduce smoking or physical inactivity or high blood pressure? Where should they target their resources? Really, this is the primary use of attributable risk. So let's use this example. This is from the textbook. How much coronary heart disease mortality, this is disease of the arteries that supply the heart muscle. So how much coronary heart disease mortality is the result of sedentary behavior versus high blood pressure versus obesity and so forth? And again, this can help entities, governments, researchers know which risk factor or factors to target with their time and resources. So in order to talk about attributable risk, we're going to talk about three particular calculations today. We're going to talk about the attributable risk fraction, ARF, the population attributable risk, PAR, and the population attributable risk fraction, PARF. These are all related but a little different. So let's start with the attributable risk fraction. This estimates the total risk of disease from a particular risk factor. The key part of this is bolded on your screen. It's among those exposed to that risk factor. So it's calculated by the risk in the exposed minus the risk in the unexposed, all of that divided by the risk in the exposed. So this is table 2.6 from your textbook. It's a 2x2 table. You'll notice you've seen this before. So what we're looking at is the risk factor is being sedentary. That's the risk factor. So if the risk factor is active, by default, that person is physically active. And then we're looking at, as the outcome, coronary heart disease. So they either develop the disease or they do not. So you can see calculated on the right-hand side of the table the incidence rate of disease. The number of new cases in those who are sedentary is 6.7%. The number of new cases in those who are active is 2.5%. So we've already calculated in a previous lecture the risk difference simply by taking 6.7 minus 2.5. Here what we're doing is just adding another component to that. We're taking the risk in the exposed, that's the risk in the sedentary, that's 6.7%. Subtracting the risk in the unexposed, that's those who are active, so that's 2.5%, and then simply dividing all of that by 6.7 again. So there's the math on the screen for you. That comes out to 0.627 or 62.7%. That's the attributable risk fraction. So what does that mean? It means that among those who are sedentary, that's the key phrasing here, only among those exposed to the risk factor, 62.7% of risk for coronary heart disease is attributed or comes from sedentary behavior. So once again, only among those who are sedentary, more than 60% of the coronary heart disease risk comes from sedentary behavior. That's how we would interpret the attributable risk fraction. Now let's talk about the population attributable risk. The word population is key here. This is the risk of the disease in the total population. So not just the exposed, but the whole population minus the risk in the unexposed group. basically it allows us to tell how much risk in the whole population is coming from some risk factor. So it's simply the total risk, or I'm sorry, the risk in the total population minus the risk in the unexposed. So if we use this same exact data that you've seen previously, same table, the risk total would be calculated by the total number of people who develop coronary heart disease, that's 500, divided by the total number of people in the 2x2 table. That's 500 plus 9,500. So that's 10,000. So 500 over 10,000, and then we subtract the risk in the unexposed. Okay, so remember, unexposed is active in this scenario. So there are 100 people who were active and developed the disease, and there were 4,000 people who were active overall. So 500 divided by 10,000 minus 100 over 4,000 comes out to 0.025, or if you put this in a more understandable format, you can multiply that by 100 and you come up to 2.5 per 100 per year. So what that means is that for every 100 cases of coronary heart disease per year, in the whole population, 2.5 of those can be attributed to sedentary behavior. Another way to think of that is 97.5 come from something other than sedentary behavior. So for every 100 cases, 2.5 come from sedentary behavior. But again, this is in the entire population. The population attributable risk fraction is very similar, but now it's going to be expressed as a percentage. This is a little bit more user-friendly, I think. So this is defined as the percentage of risk of disease in a population attributable to some risk factor. So percentage is the key here. It's different from the previous slide because it's a percentage. So you can see the calculation is the same as the PAR, except that you divide by the total risk again at the end. So let's use the same data. You come up with the same numbers as the previous slide, 0.05 divided by 0.025, but you just divide again by the total risk. So you get 50%. So what does that mean? That means that 50% of the total risk for coronary heart disease in the population is attributable to sedentary behavior. Or another way to think of this is, if everyone stopped being sedentary, half of coronary heart disease cases would go away or would not exist. So half of the coronary heart disease in the population comes from sedentary behavior, according to this. Now let's switch gears a little bit and talk about diagnostic testing. Sometimes you go to a doctor and you have some kind of testing done. The example I'm going to be using today is a test for strep throat, or flu, or something like that. You also may have testing for, there are various screening tests for cancer, all kinds of diagnostic testing. The exact same information is used in these calculations that we're going to be talking about, that is used to calculate odds ratios and relative risks, but they have a little bit different purpose. The purpose is to predict the odds that a person actually has a disease based on the results of a lab test. So we tend to think that lab tests are always correct, but that's not actually the case. There are sometimes mistakes made. The tests rarely are 100% correct all of the time. So often these are used in preventative medicine. So here are a few definitions before we go into the sensitivity and specificity, which are what we're really going to be keying in on. So a true positive is the patients who truly have a disease who also have a positive test. So the test correctly identifies them as having the disease. So if you think about a flu test, the person really has the flu, and the test says, yes, you have the flu. A true negative is when a patient has the disease but has a negative test. So the patient has the flu, but the test says they don't. A false positive is a patient who does not have the disease but has a positive test. So the patient doesn't have the flu, but the test says they do. And then a false negative is a patient has the disease but has a negative test. So a patient has the flu, but the test says they don't. So obviously you want true positives and you don't want any of these other outcomes. Sensitivity is a measure of, it tells us, it's one of the ways of telling us how good a test is. It's the probability of a positive test if the diagnosis is positive. So if they really have the flu or whatever, do they get a positive test? So it is calculated as the number of true positives divided by true positives plus false negatives. So here's an example. Say you have a test for strep throat, and the 85% of tests are true positives and 2% are false negatives. We would then calculate the sensitivity as 85 divided by 85 plus 2 is 87. So that comes out to 97.7%. So what that means is if you really do have strep, the test correctly identifies that almost 98% of the time. So that seems pretty good. Here's a visual for you. This would be a test with 100% sensitivity. So the blue dots represent somebody who really has the condition. Let's think of it as strep. And green are those who do not have strep. So for sensitivity to be high, all of the blue dots have to be in the positive test. So 100% sensitivity, if you have the disease, the test always picks it up. That's 100% sensitivity. It doesn't mean that you don't have some of the green dots in the positive test too, which is also not good. But sensitivity is its ability to pick up the true diagnosis or the correct, positive diagnosis every time. Specificity is a little bit different. You can have high sensitivity but not high specificity. This is the probability of a negative test if the diagnosis is negative. So it is calculated as the number of true negatives divided by true negatives plus false positives. So if we go back to our strep throat example, say there are 95% of the tests are true negative and 5% are false positives, then we would calculate specificity as 95 over 95 plus 5, or 95 over 100. So that means if you don't have strep, the test correctly tells you that 95% of the time. So this can be, strep is, kind of a mild, benign example, but if you think of it as cancer, if a doctor tells you you have cancer, you hope that they're correct. And if a doctor tells you you don't have cancer, you also hope that they're correct. So the sensitivity and specificity of certain tests are very important to establish before they're widely used. Here's a picture of 100% specificity. So again, the blue dot means has the condition has strep. Green means they don't have strep. So for specificity, to have 100% specificity, all of the green dots need to be in the negative test box. You can have some mistakes with the positives. Specificity is only concerned with the negatives. So you want a test to have high specificity and sensitivity. Today you're going to participate in Epi in the News 2. It is going to hopefully show you some of the importance, the application of sensitivity and specificity in and some of the ethical dilemmas associated with it.